I think that it's going to make people reconsider just sort of a knee-jerk response in terms of one seizure, not epilepsy, two seizures, yes, epilepsy. There actually is a new definition of epilepsy from the International League Against Epilepsy, which segues nicely with this guideline, because that new definition is that it is not the number of seizures that you've had that define you as having epilepsy. It's the likelihood that more seizures will happen. And if you have a single seizure but you have many risk factors, then the likelihood another seizure will happen actually is almost as high as if you have two seizures. You know, one way to know whether other seizures will happen is that another seizure happens. But why wait that long if you have other evidence that can get you there and allow you to make a decision in some cases to treat and prevent that second seizure? For some people, seizures are incredibly disruptive, scary, and potentially dangerous events. And why wait for the second seizure to be able to treat when you could actually treat after the first seizure? There are many people that we see, for example, young people who may have had too many alcoholic drinks and then they stayed up all night and they really stressed their brain in a very specific way and have a seizure. EEG, MRI are normal, and you can just reassure those people that the likelihood of another seizure is quite low, 20% or less. So those are the people that I think most people would agree not to treat. But you know, the way I have been sort of explaining it is, if you have a small fire in your kitchen and you bring the inspector out and the inspector looks around and says, you know, there may be some faulty wiring here, and it may cause another fire, you don't necessarily wait for the next fire before you have those wires fixed. Mostly it is neurologists. Hopefully general practitioners will also look at these and, again, not just discount a first seizure, will do the evaluation or send the patient for the evaluation to the neurologist that's necessary to determine the risk of a recurrent seizure. But we also think that these guidelines are for patients, because the patients need to also be informed that this is a shared decision-making process between them and the physician. And they shouldn't accept from the physician, oh, you know, always treat or never treat. It should be based on the patient's wishes and desires, as well as the evidence and information that the doctor is giving them. They are one piece in the puzzle, talking about very early in the course of somebody with epilepsy. There are other guidelines that are in process from the Academy of Neurology. A guideline that should be coming out within the next 6 months or so will talk about all of the new seizure medications and update people on what their benefits are, what their potential risks are, and that's going to be very helpful in allowing people to choose the best medicine for their patients. There are many other guidelines on epilepsy that have been, you know, for example, this one is on treatment of the first seizure. We already published a guideline a couple of years ago on diagnosis of the first seizure.